Hello and welcome to the COMLEX Instant Review. Today we're going to be reviewing some of the high-yield topics in hyperbilirubinemia for pediatrics. So let's go over some of the high-yield topics. Now, if the baby has any features that are outside of those listed for physiologic jaundice, you must presume that the baby may have pathologic jaundice. Now, we had talked about physiologic jaundice and biliary atresia in the earlier podcast. But how do you work up a patient for pathologic jaundice? Well, step one includes looking at the mother and the baby's blood types for a possible isoimmunization. Now, what are the most common mother and baby ABO types for this to occur? Well, you have to rule out the OA and the OB classes. And what maternal blood type would not be consistent with the diagnosis? That's an AB positive. What are the other lab findings that would support the diagnosis of ABO incompatibility resulting in isoimmunization? Well, a decreased hemoglobin, a hematocrit with increased retics, and a positive direct Coombs test. So those three things would actually support the diagnosis of ABO incompatibility resulting in isoimmunization. What is step number two? Well, this involves looking at the isoimmunization. If the isoimmunization is not the explanation, then you look at the hemoglobin and or the hematocrit, and there's a specific algorithm that you can follow for pathologic jaundice not due to RH or ABO incompatibility. Now, what you have to look at is the HNH from the CBC that you obtain. If the HNH is high, then it's polycythemia. You're thinking of causes such as intrauterine growth retardation, asphyxia, also diabetes mellitus, twin-twin transfusions, maternal fetal transfusions, and delayed cord clamping. If the HNH is normal, you're looking at causes such as cephalohematoma, bowel obstruction, poor breastfeeding, breast milk jaundice. And if the HNH is low, you're looking at causes with high reticulocyte count, and that includes looking at the smear. If the RBC smear is normal, you're looking at an enzyme defect, and if it's abnormal, then you're thinking about a membrane defect. So, just to review pathologic jaundice and the workup. First of all, you're going to be looking at the ABO compatibility test. And the most common mother-baby ABO types for this to occur, we said, are OA and OB. And then the maternal blood type that would not be consistent with the diagnosis is AB positive. Next, you're going to look at other lab findings. If you suspect and determine that the isoimmunization is not the explanation, then you're going to look at hemoglobin and hematocrit, and you're going to work up the patient for pathologic jaundice not due to RH or ABO incompatibility. Look at the HNH. If it's high, you're thinking of causes of polycythemia. If it's low, you're looking at a reticulocyte count, which is high, and then looking at the peripheral smear for a membrane defect or an enzyme defect. And if it's normal, looking at causes such as cephalohematoma, bowel obstruction, poor breastfeeding, or breast milk jaundice. Now, what are the differences between breastfeeding and breast milk jaundice? Because this is a high-yield topic that may show up on the board exam. Breastfeeding jaundice occurs generally during the first few days. It has increased enterohepatic circulation, rehydration and phototherapy, if needed, are recommended. And you also want to teach proper breastfeeding by consulting a lactation consultant. And it should no longer be a problem with proper skills. So, again, breastfeeding jaundice occurs during the first few days. It's due to increased enterohepatic circulation, and rehydration and phototherapy may be needed, and lactation consultant as well as appropriate technique is recommended. Now, breastfeeding jaundice is generally during the second week, and breastfeeding jaundice occurs mainly because the breast milk contains an inhibitor to the baby's gluconeural transferase. You want to stop breastfeeding for 48 hours, and after the bilirubin decreases significantly, it is okay to breastfeed. And again, understand that it will gradually decrease jaundice over the next 2 months, and expect that the bilirubin will go up again somewhat with the breast milk, but less than the maximum. And again, it will continue to decrease after that. So that's a key topic you want to keep in mind. Finally, one last question that we want to review is, what is the basic principle of therapy for breast milk jaundice? Well, it's phototherapy, and it's through the exchange transfusion. So if the bilirubin continues to rise and gets to 25 milligrams per deciliter, then exchange transfusion, cross-typing, and giving the baby fresh blood via the umbilical cord is recommended. So those were some of the high yield points for hyperbilirubinemia. We had covered topics such as working up a patient for pathologic jaundice and the differences between breastfeeding and breast milk jaundice. Good luck in your preparations for the board exams, and visit COMLEXFlashcards.com for additional resources.